I've got a quiet voice, so if you can't hear me at the back, please shout out. So thank you, Chris and Dan, for inviting me to share the experience that we've got from NHS Scotland. I know time is tight, so I'm going to whiz through my presentation. Quite a few slides I won't talk about at all, but what you'll have at the end of it is a complete slide deck, which will hopefully be more meaningful to you when you look at it later. So what I plan to do today is set out the context within NHS Scotland. Okay, great. We had three main drivers for change, and I just want to share those with you. I really am going to summarise our approach and learning and then point to where we are concentrating our efforts in terms of our next steps. I think it would be a fair summary to say we've made good progress, but we are still in the learning phase. And in actual fact, I've learned already from what you've done in Canada, because we did not take this approach of having these multi-stakeholders in the room to start at the very beginning of the conversation. And while it might appear when I present that we were quite chronological and systematic in our approach, that was not the reality at all. So don't be misled by that in any way. It was quite serendipitous and quite opportunistic a lot of the time, and there's a lot of going back to go forward. But I'm not going to put you through the pain that we've been through, but you need to know that it wasn't as straightforward as it might appear. So in terms of Scotland, I'm not going to bore you too much with this, but I don't know how well you follow the politics in the UK, but Scotland is still part of the United Kingdom, but we have a completely devolved health service, which is managed by the Scottish Government. We've got about a sixth of the population of Canada, and I did a bit of Googling beforehand, and we've got the landmass of New Brunswick. Is that right? Am I right? I think it is. It's tiny. So the concentration of people to land is quite different. And about 10% of our medicine spend, 10% of our NHS spend is on medicines, which I think is comparable to Canada. So we have 14 territorial boards set out in the geography, the tartanised geography you have in front of you, and we have 5 support boards, and I'm the chief pharmacist of one of the support boards, which my responsibility is around improvement. Okay, so we have support boards around education, data, out-of-hours services, etc., etc. Big policy drive in NHS Scotland, and now NHS England actually, is around integration of health and social care, which is, biosimilars is challenging, but health and social care integration is really, really challenging. So, very quickly, my organisation, I suppose the key message here is that it's a unique model because we've got assurance and improvement and evidence all in the one organisation. That creates great opportunities, but creates some challenges too. And we've got Scottish Medicines Consortium, which is our health technology appraisal body in our organisation. So drivers for change. There were 3 main drivers for change that started this work off in Scotland. Obviously, the fact that we spent a substantial amount of money on biological medicines. 9 out of the top 20 medicines by spend in NHS Scotland secondary care were on biological medicines. We knew that they were about to lose their patent in the next 5 years. And so there was a financial opportunity that we had a responsibility to explore. We also were aware of work that was being done very close to us in other European countries, and this is a graph which you may well have seen already from your presentations of the uptake on Artanercept in Denmark. Within 4 months of the biosimilar coming to market, they had 95% coverage with the biosimilar. And so there was a lot of pressure for us in Scotland to replicate that model, and that was, as I understand it, a procurement-led model. And so that was part of the drivers for change. We also had, and again, I don't know what the Canadian, gosh, that was a faux pas, sorry. The Canadian situation is, but as a result of the financial downturn, we have got some real financial challenges in the delivery of our public services. And we, I think, estimated that last year, this year, and next year financially were going to be the really, really crunch years for us, and they are really, really crunch years. There really, really is limited money. But we had made a policy commitment around transformational change around integrated health and social care. So a very high level mechanism was put in place, oversought by the Minister, Cabinet Secretary, chief executives and chairs of all the boards, to look at how we could get transformational change in NHS Scotland. And they had a few focus areas that you'll see down the bottom of that chart, which is the bit that I want you to look at. And prescribing is always one of the areas that they want to see improvement in Scotland. It's always a focus. I think we almost always deliver on that. But effective prescribing was one of the work streams, and biosimilar medicines was one of the priority areas within that work stream that we were asked to consider. So they were our drivers for change. So what did we do? So the process for managing the introduction of new medicines in Scotland, I think, is quite similar to Canada. I think there are some differences maybe around negotiation, but it's quite a similar system. And this is a very well established and very well embedded system within NHS Scotland. So the regulation of medicines is a reserved matter, so it's still undertaken at a UK level, and for biological medicines it's a European actual decision that's made. But the regulators, just to get that out of the day, have been very clear for a long time that they have been enabling around the use of biosimilar medicines. So they do not expect or require any redemonstration of the evidence, and I think that may be similar to yourselves. And a biosimilar is annotated, that designation, if there's no clinically meaningful differences identified around quality, safety and efficacy. And I'm not going to go over that again because I know you've touched on that. So that we would see would be an enabler which was already there. The Scottish Medicines Consortium requires all new medicines that get a licence to go through its HTA process. But a decision was made in 2015 based on the HTA experience that we had of looking at about 11 biosimilars, that was not adding any value in the system. And so we took that out and made that out of remit for SMC. And so now any new biosimilar that comes to the market that has its regulation, where the originator has already been through SMC process and approved, does not go through our HTA process at all. So we would see that as being a key enabler, and that takes away some of the time delay because it's 18 weeks to go through the SMC process. Once SMC have made a decision around a new medicine, we then have board decision-making processes, because not everything that gets through SMC would necessarily go onto our board formularies, as we call them. But again, we got cross-Scotland agreement to take that out of the system. And so again, if a biosimilar, once it gets its licence, it's readily available for a clinician to prescribe. So there's no national HTA process, and there's no board processes that need to be gone through. It automatically is available to the clinicians to prescribe. So these are two big enablers that were relatively easy to get through the system, to be honest, and we refer to them in the framework that's mentioned today. So the bulk of our efforts have been concentrating on this last but critically important part of that chain, which is that individual prescribing decision made by the clinician with the patient. And so that's where our efforts have concentrated. And on this bit that's running along the side that I've not mentioned yet, but is quite separate from that process on the left-hand side, is our national procurement, which is where the negotiation takes place. And that is completely separate from all of these other steps, but is obviously clearly related to it, and it's an ongoing process. So I'm going to whiz through. So I think this is getting a wee bit stuck here, Dan. Oh. Okay. So, in addition to those enablers that I talked about in terms of HTA and our board processes, we were asked specifically to do something to help that conversation between the clinician and the patient and to support clinicians in that decision-making process. So we got together a group of wide range of multi-professionals and different disciplines. So we had oncology, rheumatology, gastroenterology, dermatology, diabetes, basically any clinical group who prescribed biological medicines together as an expert group to develop our national prescribing framework. And this was with a view to further enabling access to biosimilar medicines. And I'm not going to go through that in detail, but I'm going to give you the headlines, which is that we made a decision that biosimilar use should be a clinically led approach. So that was fundamental to our decision, which was different from what had happened in other countries in terms of a procurement or a finance-driven decision. We recommended that biosimilars were a legitimate alternative to the biologicals, and that may seem like a daft thing to say, but I don't think everybody came into the room thinking that, and so that was an important thing for us to call out. Whilst we knew that there weren't any efficacy or safety concerns, we did recognise that clinical experience was still emerging with these medicines, and that was important to recognise that, because that was going to continue to be a barrier if we didn't call it out and work on providing that comfort around and confidence that the clinicians were seeking. And so we recommended that biosimilars were suitable for new patients and encouraged switching, but that switching again had to be clinical led. There was a huge amount of nervousness about it being a financially driven programme of work. And so we were very, very clear that it needed to be clinician led. And I think we call out in the framework that interchangeability at the dispensing point was absolute no-no. And I think quite a few countries have stated that. Certainly quite a lot of European countries have stated that. So that framework, however, was done in 2015, and a lot can happen in 2 years. And when we did that, you know, I was speaking earlier to our colleague here, I was saying that the British Association of Dermatologists on their website, on their guidance, was very, very clear that biosimilars were not to be used at all in dermatology. Gastroenterologists said we can use it for new patients, but don't switch with it. I can't remember what the rheumatologists said, but they were in quite a different position from where we are now, 2 years down the line. So if you track their guidance, they've all updated their guidance, and they have all shifted in their thinking. So the dermatologists are now saying, yeah, okay, you can use it in new patients, but you can't do switching. The gastroenterologists are much, much more confident, and they're saying you can use it in new patients, and we are comfortable with the switching process, as are the rheumatologists. So it is, I think I completely agree with what Dan said. It's a really rapidly moving field, and that's one of the challenges, is keeping on top of that. So the point about the uncertainty, maybe just think about that in a little bit in detail, because the framework we did had all of those specialties in the room, and perhaps naively we thought that we could come to a common position on it, and I suppose we did at a very high level. But what was absolutely clear from the conversation was that a one size does not fit all, that these specialties all have unique differences which have to be considered. And so we have taken a very specialty specific approach to follow-on work. And so I think Dan touched on it earlier on. There are some clinical considerations and some really, really practical considerations that need to be taken into account when you're looking at how you're going to approach biosimilars use. Well, that's from an NHS Scotland point of view in terms of how we construct our services. And also the actual individual products create some challenges too. So we were asked to do more. If you remember the diagram I put up earlier under transformational change, which is a chief executives-led group, our chief executives pretty much said, that's great, all these enablers that you've done, we've got the framework, we've got the HTA and the board processes, but we want to do more to drive change. So we set up a biologicals project group, and the rationale for putting up the faces is just really to put the faces to the names and to make the point that myself and Alison's a medical director of one board in Scotland, and I'm chief pharmacist of one support board. But we're doing this work, absorbing this work as part of our job and as part of our corporate responsibility for the NHS. So that's the approach that we've taken. But we've had additional capacity, credibility, clinical leadership by bringing in gastroenterologists and rheumatologists on a sessional basis to support the work, and we've had programme support also to support us. And whilst I've been really clear that this is clinically led work and not national procurement led, we've worked really closely with our national procurement colleagues, and they take a lot of the credit for some of the progress that we've made. So the ask from the chief executives was to save money. Okay, so they wanted us to do the same with less. So the green middle box, I don't know if I can get this to work. No, I'll not bother, was where they started from. However, because of some of the things I've already touched on, and some of the very specific challenges I think we've got within the NHS, we realised quite quickly that there was a greater opportunity. There was a greater opportunity both in terms of the financial savings, but also improving the quality of care for patients if we went for a do more with less, a quality improvement and savings approach. And we knew that the engagement with the clinicians was going to be critical to success, and we were not going to be able to get them involved in a meaningful conversation if it was just about saving money. They wanted to see the benefits for patients and clinical practice in the changes that we were making. So within a fairly short space of time, 6 months at the most, we shifted the agenda from that green middle box to the right-hand side where we were doing more with less. And I think that has been key to securing the clinical buy-in and sustaining that. We also had at the same time our Chief Medical Officer's report on realistic medicine, and those themes I think fitted perfectly with what we were trying to do with biological medicines. And while we recognised there were different drivers from the managers, the chief executives and the clinicians, I think that the improvement in the use of biological medicines as a broader agenda than just biosimilars allowed us to deliver the aspirations of both managers and clinicians. So I'm not going to talk about this in any detail. I don't know if you're familiar with realistic medicine, but shared decision making, personalised care are central to how we are trying to drive the NHS in Scotland. So the biosimilars workstream became the biological medicines workstream. And so this is now our aim of what we are doing. So we're driving improvement in the use of biological medicines, including biosimilars, to deliver quality improvement and financial savings. And we put in place multiple interventions, which are listed here. And some of these I'll go into in a little bit more detail. But procurement was key to success. We nominated biological leads in each of the territorial boards, so that we had a go-to person in the board to get ownership and to drive change at a local level, in addition to appointing the national clinical leads that I've touched on. We hosted specialty-specific engagement events. Specifically, we've had 2 around gastroenterology, 2 around rheumatology, and we've just had one on oncology because we've now got rituximab biosimilar available in the UK. So we also took a bit of a carrot and stick approach, and I'll talk about that in a little bit more detail. So the sharing good practice and the targets, I'll give some examples of what we've done there. So it was not a single intervention. In terms of our clinical leads, they focused on 4 particular areas of work, and I'm not going to talk this through in detail. I'm just going to touch on something that they've done around evidence gathering and about the infrastructure. So in terms of sharing the learning, and this is in terms of driving improvement, they've done a lot of engagement with the biological leads and the clinicians and the boards, and they've collected evidence about good practice. So in amongst this, or in addition to the national work we were doing, there's local change taking place. So we collected them, wrote up case studies, and we've published that, and that's on our website. But the 3 factors to success were strong clinician and manager buy-in to get to the same aim, an invest to save approach. So quite a lot of boards invested resource, nurse time, pharmacist time, extra clinic time in order to make the change to get the savings out. And that conversation with the patient was absolutely central to the key to success, and that came out strongly in all of the case studies. I want to specifically talk about something around infrastructure, which may or may not be relevant to you, but it was around therapeutic monitoring, and this is what came up from our conversations with the clinicians in gastroenterology in particular, that the barriers to success were they didn't have good data. So we don't have good data in the UK, but in Scotland around outcomes and usage. Okay, and therapeutic monitoring would help to give greater prescriber confidence. And there were some real challenges around the logistics of how we provide the service. So the therapeutic monitoring, this paper was presented at a recent EU conference, which shows that with the addition of a therapeutic monitoring service in gastroenterology, 68% of patients, there's just under 200 patients in this study, 68% shifted to a biosimilar. Some most on the same dose, but some with some dose modifications. 17% of patients stopped the medicine completely. And when this work's been repeated in other boards, there's been actually a higher stop rate of biological medicines. So we've now going forward with this autumn to have a Scotland-wide therapeutic monitoring service, which will help to get that clinician confidence around making decisions about changing, switching, reducing doses, stopping treatment. We also mentioned the carrot and stick. We've done a bit of a push out. So we did set targets around uptake, and we did monthly comparative uptakes of the boards that we sent to everybody. And that created a little bit of noise and it created a little bit of competition. But it was actually really quite helpful, I think. So the targets, I'm not going to go through this in detail, but we set targets for 217 and 218. We met the 218 targets by the end of 217. So our chief executives are very happy with the progress, and these were realistic but stretching targets that we set. So the key learning is, I think, I would share with you is that the opportunity is broader than biosimilars. Improving the use of biological medicines is where we are in Scotland. We've had to take a specialty-specific approach, and the conversations that we're having around oncology and rituximab clearly highlight that there are really quite different and complex issues in each specialty. We had a mix of interventions, incentives, and a little bit of a carrot and stick approach, and I think that's worked reasonably well. Clinical leadership, clinical engagement has been absolutely key to success, and having that buy-in from the chief executives, and in actual fact that focus on the chief executives is a bit of a double-edged sword to be under that amount of pressure and reporting to them every month, but in actual fact it has allowed us to fast-track change. We are working in a complex health system, and collaboration has been critical, and it's not always been easy. So at the moment we've not got any clinical or patient concerns emerging, and we don't have any evidence of safety or loss of response, and there is a UK-wide IBD audit going on, and it gets more positive every time it reports. So our next steps are focusing on the new biosimilars coming in. We aim to get our work into business as usual so that we don't need this additional mechanism, and we've done some other work around improvement in rheumatology, which is part of the slide set, which you can see later on. And we're preparing for adalimumab, which is the big issue for us in 2018. So a slide to finish, which is slightly easier on the eyes, and some of the other nice bits of Scotland. So thank you.
Stay there for a few minutes. Thank you very much indeed. I think that's... you can see everyone has been really, really interested, and thank you so much for running through it so quickly. And I think that gives us a few minutes, just a few, for, I think at this point, factual questions. So obviously there's time for discussion as the meeting progresses, but are there any quick sort of factual questions about how the approach that Laura's been describing works in Scotland? Yes, please. Yeah. So microphones are coming and they're working.
So Laura, when you spoke of the carrot and the stick, I didn't hear much about the carrot, only about the competition. Was there any gain sharing that occurred if you were successful in your region? Did you get to use some of that resource to enhance the service otherwise for your patients and models of care or such things?
Yeah, I suppose we haven't got time to go into that in a lot of detail, but I suppose the therapeutic monitoring, the issues we've got around data, the clinicians would see those as wins. But the invest to save approach, as you might call it, gain sharing, it's not gain sharing in terms of explicitly being able to treat more patients, but they've got investment in additional clinic time and resource to actually treat their patients better.
So I wasn't referring to more medication I wasn't referring to using more biologics and more patients, but more to the second point.
Invest to save. So that's absolutely been the key to success, has been invest to save. So additional clinic time and perhaps a pharmacist nurse to support the change. Yeah.
Laura, can you explain at all if or how patients had been involved in developing this framework? Okay, sure. So we had patient representation on the expert group that developed the framework, and at every single workshop that we've had really, really good patient engagement. So both in all rheumatology, gastro, and in oncology. We've developed patient engagement tools, so sort of standard letters that the boards can use to communicate with their patients around the change as well. So they've been an integral part of the work. Interestingly, they've been much more pragmatic, I think, a lot of the time than the clinicians, and have been comfortable about the change as long as
they are assured that some of the money that's saved is going back into reinvestment of the services for them.